This is Jay Garlitz, AA4FL, Hawthorne, Florida, operating as Whiskey Bravo 5 Delta today. The Medical Amateur Radio Council Grand Rounds on the Internet, which meets every Sunday. Traditionally, physicians rounded Monday through Saturday. Sunday mornings is, of course, a time for church and family. But in the particular case for physicians, it became a tradition to have on the air discussions on Sunday morning, since that was a day they didn't have to round as frequently. So thank you for understanding that. We do record for our members on YouTube to make it available to people that have members and the public that have conflicts. So if you're watching this video and you're part of the general public, this is an amateur radio net. It's not medical diagnosis, but that's our passion here. It's health-related subjects, and that's what we're talking about today. And I'm going to be passing over momentarily the microphone to N5RTF, who's a psychiatrist and retired psychiatrist in New Orleans, and Manir Elawar, N3PQ, also a retired neurologist here from Pennsylvania. We also have AI-generated information that's been researched by Michael Dodson. I apologize for the misspell on the printout here, Mike. Mike, I believe you were an attorney in Tallahassee, so we're going to get a little different perspective. And I think it's important that Mike's input when we see what people are generating through AI. And at the end of our presentation, we're going to kind of look and compare and contrast to see what AI generated. You know, when we teach these days, those of us that are still in education now, we're trying to emphasize the higher level learning, and now with AI. Students use it, people use it in the public, and somehow we have to train them and how to apply that as a tool, and not to take it verbatim and assume that everything that we find on the internet is true. We encourage all members and guests to participate by asking questions and providing input whenever possible. We need an amateur radio license, a general license or higher, to be transmitted on the air. This is a roundtable discussion about the subject, not medical diagnosis or recommendation. So we often focus on medical subjects because health and amateur radio, that's our passion. We were formed in 1966, the Medical Amateur Radio Council, and we are an American Radio Relay League amateur radio club, but we're also known as Healthcare Hams. We have a YouTube channel, and this particular interactive Zoom 20-meter discussion today is being recorded for YouTube video and will be available to the general public to view. And the Healthcare Hams does have that YouTube channel. So if you just go to YouTube and search for the Healthcare Hams channel, we have a number of videos. We have 35 videos of various subjects. They're not all medical. Some are amateur radio. Some are almost more social science, where we talk about different holidays and the reasons behind them and the medical connections. So at this point, I'm going to turn the microphone over here to N5RTF Chip. Go ahead, Chip.
Okay, this is N5RTF. As Jay said, I'm a retired psychiatrist living in New Orleans, Louisiana. And I've worked probably for over 40 years diagnosing and treating, among other things, people with dementias. And I've seen this refined through the years. The first patient I ever saw was said to have hardening of the arteries. And then during my residency, I saw a patient actually diagnosed with Alzheimer's disease for the first time. But one of the problems is there's never been really good tests for Alzheimer's and other dementias. There are some that attempt to test, but around 1987, a researcher named R.L. Doty wrote an article on deficits in detection and identification of odors by patients with Alzheimer's disease. And he suggested that a smell test might be used in conjunction with cognitive testing, which was the definitive test at that time for the disorder. Since then, there are several teams of researchers who have added to this concept. And recently, an article came out in the popular press about an at-home smell test that is remarkably accurate, 70 to 80% accurate, inexpensive, and can be done in the privacy of your own home. For people with mild cognitive impairment, they can self-administer the test. For people with more advanced dementias, a family member can do it. So it really improves the ability to test. So the question is, how accurate is this? And why would you even do it? Well, 10% of people over 65 have some form of dementia. Once you get up to 20%, once you get up to age 80, it becomes 20%. Early detection of at-risk individuals, it provides the patients and their families time to plan for the future. It also identifies persons who might benefit from some of the newer prevention and treatment strategies and trials. It's also valuable for research. So how do you find out now if somebody has dementia? A comment? Feel free to interrupt at any point if somebody has a comment. This is not a broadcast. This is a net, and we are fielding questions continuously throughout this presentation.
May I say something, Chip?
Yeah, Manir.
Yeah, as you know, while this is an extremely interesting topic, I know we're going to discuss smell, and we will use CT scans, MRIs, PET scans. I just want to put a plug in for something that's been a lost art, which is like taking a very good history. And I know my generation, your generation, we counted a lot on that. A very thorough history and a good physical exam, because that can go a long way to making you suspect or even diagnose a condition.
I agree. And it's, if you have a reliable family member who can say with confidence that the person is not the same as they were, say, 5 years ago, 10 years ago, and can point out the differences, that goes a long way. If you are in primary care, and I have been in the past, and you have followed patients for any length of time, you can see this yourself in people as they develop dementia. They start becoming forgetful, word hunting, name hunting, might get lost to coming to your office where they've been 100 times before. So you might be the first person to notice it. The tests that are used to make the diagnosis now include CT scans, MRIs, PET scans, testing for amyloid plaques, genetic testing. Spinal taps can check for abnormal proteins in the CSF, and neuropsychiatric testing, which is a day-long battery of pencil and paper tests. Obviously, that would be at the milder edge of the dementia spectrum because it is fairly complex. All of these tests, including the pencil and paper test, cost thousands of dollars. And the accuracy ranges from about 60 to 85%, depending on the test and depending on the types of dementia. So they're not perfect and they are expensive. There is no single absolute test for any specific dementia. So that's good to hold in your mind as we speak. So you can't go in and just get checked for Alzheimer's disease. It's not possible. So back when I was in medical school, which was about 50 years ago, my professors bemoaned the fact that the students were not learning physical examination, and they were going straight to lab and radiology to make their diagnoses. I'm sure that it's even more prevalent now. People are pushed for time. They need documentation to collect insurance. If you don't have the right lab test, you can't make the diagnosis and you can't get paid. So people are putting physical examination back on the shelf. It's not reimbursed on the same level as some of the more expensive tests are. And it doesn't have in the public's mind the same reliability. Although as physicians, most of you realize that it is extremely good if you know what you're doing and you have the experience to go along with it. Smell is testable, and it's testable with fairly easy tools that are available to just about anybody and can be done in as little as just a few seconds as part of a physical examination. Also, when you're taking a history, you can just simply ask somebody, have you had any problems with your sense of smell? And people might tell you, yeah, things don't smell as strong as they used to, or they smell different than they used to. When you're working up a patient with a weight loss or adult failure to thrive, one of the important questions is, how does your food taste? And if they say that the food doesn't have any taste to it, most of what we call taste is actually smell. So they can lose their sense of smell and their ability to taste things. Their perception of how things taste goes way down. And if food doesn't taste good, then they're just going to stop eating. And weight loss is a sign of problems sometimes with sense of smell. Smell is the oldest sense. It's cranial nerve number one, and it is present and functional in all tetrapods. That includes everything that crawled out of the ocean: amphibians, reptiles, marsupials, and mammals. All of us have a sense of smell.
Pause one here for identification. That's N5 RTF at the microphone, and it was Linear N3PQ offering input. You're operating on amateur radio, live on the air, as well as a Zoom simulcast. And we appreciate those on the air that are allowing us the use of the open frequency. Today's transmissions are originating out of Hawthorne, Florida, my home station, Alpha 4 Foxtrot Lima. This is not medical advice, but obviously we have a passion for the subject, and we're having a roundtable net discussion where everyone has the ability to not only ask questions, but also to give input, because it's so prevalent in our families, this disease process. That being said, I'm going to turn the microphone back over to N5RTF. Dr. Keister, go ahead.
Thank you, Jay. This is N5RTF. At the risk of putting people to sleep, I'm going to do a little bit of the anatomy and physiology of what we're talking about. As I said before, smell is mediated through the first cranial or olfactory nerve. Scented molecules enter the nose, wash across the roof of the nasal cavity as we breathe, and the upper turbinate. And there's just a small, about 1 square inch area that has these special cells that join with the particulate matter in the air and can actually transmit the information to neurons in the brain. These have to go originally through the nasal epithelium. Then they have unmyelinated axons that go through the cribriform plate. If you've looked at a skull, that's tiny little perforations through the upper part of the nasal bone, where these little nerves go through there into the brain itself. And they go through the blood-brain barrier in a very complex manner to try to keep bacteria and viruses out. And they do routinely a very good job of that, with some exceptions. But it's a complex system and it can be damaged. Information is processed by several layers of neurons and it's routed directly to the brain. Medial fibers from the olfactory bulbs control autonomic responses like Pavlov's dog salivating. We do the same thing if we smell something good. And it's not a conscious or voluntary activity. The lateral fibers go to the entorhinal cortex, where the amygdala processes your emotional response to smells. and the hippocampus recalls the associated memories. So it's two different things. You recognize a smell, you sense a smell, and it causes an emotional reaction. Pheromones would be a good example. And then in the hippocampus, the smells carry certain memories. And if I think you'll remember, everybody's had the experience of smelling something from their childhood, a memory that may go back 70, 80 years. And they smell that, and it takes them right back to that moment and whoever wore that perfume or that candle or that food or whatever it was that smelled, it had a reaction. Hopefully good, sometimes bad, but it's very closely intertwined with the areas of the brain that control memory. And coincidentally, these are the areas of the brain that are hit first and hardest by some types of dementia. Therefore, smell, it makes sense that it would be affected early in the disease process. By the way, there are fibers from both of the nasal bulbs that go to both sides of the brain. So there's no lateralization in your sense of smell. Like you could, in your ears, you can tell where something is with your eyes closed because you can hear a difference in the tone, in the timing between the sound coming into your two ears, but you can't sniff and tell where something is based on lateralization in your brain. The smells are controlled so much more by just the wind and the environment that lateralization has no real value, and even animals don't lateralize their sense of smell. So there are commercial tests to measure smells. The University of Pennsylvania has done most of this research. It goes back a long ways, and their kit, which is the University of Pennsylvania Smell Identification Test, is commercially available, 40 items in the test, and it's about $12.50, which is very reasonable, whereas medical tests go. There's a product called Sniff and Sticks, which has 12 smellable items. These are more like magic markers. You pull the cap off and wave it under somebody's nose. They're reusable, but the whole set cost about $480, and I don't know how long it lasts. I don't know if you could use it every day for a month or 2 months or 6 months. You'd have to check into that yourself. And then there's a brief smell identification test, also with 12 items, and it's about $20. So most people are going with University of Pennsylvania, both because it's the most validated test, and it also seems to be the cheapest. It takes a reasonable amount of time to do it correctly. And they test for things like detection of smells, identification of individual smells, and discrimination between two smells. Can okay, this, I'm going to give it to you again. Is it this or is it this? And they can be administered either in a clinic or, if it's done properly, at home. And there are kits for both. And it's the results at home testing. If you've got somebody who can give the test, read the instructions and give it properly, the results are as good as they are in the clinic most of the time.
Jim?
The accuracy of this in diagnosing mild cognitive impairment and Alzheimer's disease is about 70%. Similar results have been found in frontotemporal dementia, although with less studies. But the number of cases, the number of published papers is growing, and this is a valid way to screen for a variety of types of dementias. Other dementias that where sense of smell is affected include Lewy body dementia, which is the flip side of Parkinson's disease. Parkinson's sort of starts at the bottom with motor problems and works up to the brain and dementia. Lewy body dementia starts at the top with the cognitive and hallucinations and all of that. those symptoms beginning first and then ultimately developing the movement problems. So at the end point, they're both the same disease. Traumatic,
Break one.
yes.
For ID again, Whiskey Bravo 5 Delta, Medical Image Radio Council, ran rounds of the Arnett open amateurs. But if we can just pause a second for anyone on 20 meters, I would like to check in, some late check-ins. Make your call at this time to Whiskey Bravo 5 Delta. Okay, we're not getting any check-ins on 20 meters. Do we have any questions for Chip? Yeah, let's start at 20 meters. Go ahead.
Munir, you know much more about Parkinson's than I do. You've seen a lot more patients. Any comments?
Yes, actually, I do have a comment and a question. The comment, it's certainly something I've seen in Parkinson's disease even more often than in Alzheimer's disease in my own experience, in my own practice, let's put it that way, because I relied heavily on in Alzheimer's by sending them to neuropsych testing at a university center. So I use that very, very extensive, the neuropsych, psychiatric and psychologic testing. My question is, you mentioned the accuracy. Could you kindly elaborate on that? I mean, I think we've talked about that before, but what do you mean by accuracy of 70%? This is Munir N3PQ.
False positives and false negatives, probably in the range of about 30%. They use other tests and also longitudinal observation to make an accurate diagnosis. Obviously, we don't do many autopsies anymore, so you don't have that for reference. But they find that it matches the clinical course about 70 to 80% of the time.
My concern, as I mentioned before, are the false positives. As we know, many people with neurodegenerative disease, Parkinson's, Alzheimer's, Lewy body, have difficulty with olfaction. But the reverse is not true. The vast majority of people with difficulty with smell, sense of smell, do not necessarily have a serious condition, like do not have a Parkinson or Alzheimer's disease, is the point I wanted to make.
Right, particularly in the age of COVID. There are lots of people that have smell problems associated with COVID. And we'll go into that a little bit too. Limitations of these tests. Obviously, the person must be verbal. They've got to be able to answer questions, and intact enough to follow some simple instructions. They have to be. They can't be psychotic. They can't be agitated. They have to be able to concentrate enough to sniff something and give you a verbal response. So if they're far gone in the dementing process, then the results are going to be flawed just by the fact that they can't take the test properly. There are some people who have congenital absence of sense of smell. Kallman's syndrome is an example of that. Trauma. I mentioned that those tiny little nerves go through the bone of the skull, part of the process, and those nerves have the consistency of grape jelly. So if somebody has a bad enough blow to the head, they can just shear those nerves off. Now they can regrow, but it takes time, and they don't always end up where they were in the first place. So a person's sense of smell may become impaired over time. As Munir said, there are plenty of disease processes that affect your ability to smell. COVID is known now to be to commonly affect people's ability to smell. It can be temporary, or is, you know, since we've only got a 5-year window of study, there are people who've never regained their sense of smell, or not never regained it to the point where it was before. Sinusitis can swell the nasal mucosa, so can exposure to some chemicals. Smoking is also an example. Smoking impairs your sense of smell. If you quit smoking, how much smell you get back depends both on how long you smoked and how long it's been since the last time that you smoked. And it varies individually. People work in environments where there are overpowering smells, and it affects their ability to smell when they get home. And then there are some drugs. Amiodarone is a good example of one that can actually decrease a person's sense of smell. That's been reported in numbers of cases. So there's lots of things. Marijuana, the highly individualized, and you've got to separate it from the effect of the drug itself. People say that their sense of smell goes up or goes down, or they even hallucinate smells on marijuana and other drugs. So all of that is confounding to the kind of studies that we're talking about. Sense of smell decreases with age. Everybody's does, just like just about everything else in your body. It declines gradually. So when you do these tests, the norms are set not based on raw scores, but they're based on age-related norms. So you take somebody who's 90 years old, they'll have a different comparison base than somebody who's 60. And that you'll need to read that in the instructions for the test that you give and see how it was normalized. Again, Parkinson's, multiple sclerosis, progressive supranuclear palsy, a variety of tumors, and anything that causes increased intracranial pressure from there's a dementia due to pseudo trying to think of the word. It's an increased intracranial pressure that does cause dementia, and it's one of the ones that's reversible. You don't see it very often, but it's worth checking for, and a CT will usually see the enlargement of the ventricles, and that pushes down on all of the nerves that exit the skull and can cause problems with sense of smell as well. Most people can smell and they can report their findings. If you want to do one of these tests in your office or at home, you can order a commercial kit, or you can just try some of the common scents that are known to have a diagnostic value. Written up in the literature are things like strawberry, smoke, soap, menthol, cloves, pineapple. It said natural gas, and I'm sure they're talking about the tracer that they put in natural gas, because just plain methane doesn't have any smell to it. Lilac, lemon, and leather. Those are some of the things that have been done in studies. Paring those down, there are 4 smells that seem to have the greatest clinical distinction between normal cognition, mild cognitive impairment, and Alzheimer's disease. And these are cloves, garlic, cinnamon, and banana. And I'm pretty sure most of you have those available in your own kitchen. So if you want to test a family member, you can just use those those smells just right out of the kitchen. Some of them can be put in little vials and used as part of physical examination. Very inexpensive, should be considered to be a screening test. And if the results are abnormal, then you would go on and do a more formal examination along with other tests for corroboration.
Can I mention too?
Yes.
This is N4JEL. I work at the Florida State University College of Medicine in the as a standardized patient. We use coffee and cinnamon in teaching the students how to do a basic neuro workup. Some of those have cultural elements. And if I'm a habitual tea drinker, I might really not know what coffee smells like. And if I'm from certain cultures, I may not have tasted cinnamon and know what it is. But that's one of the limitations is your cultural background. The fragrances that you mentioned would have baffled me. I'm not sure I could distinguish leather from lemon. So it's somewhat of a struggle sometimes. Thank you very much. That's my comment.
No, thank you. Thank you. Appreciate that. And thanks for working as a standardized patient. I've met a few people that did that, and it's fascinating to hear their stories.
It's absolutely rewarding.
May I add to that a little bit?
Please.
Yeah, so this is what Mike just said, very, very important. I would like to add vanilla. Some people use vanilla. But what I would like to say, if you ever gotten one of those magazines that have ads for colognes and perfumes, the synthetic, they don't smell the same as when you actually buy the cologne or perfume. And that's my concern with these standardized tests. What they tell you is this particular smell is not natural stuff, it's synthetic. So my concern is they might be able to discriminate between different smells, but they might not be able to name the different smells when you do those tests.
Right.
That was my, whenever I use those standardized tests, that was my concern with them.
And that's a valid concern. Now, within the test itself, the tests are reproducible, because even though it might not smell like leather, from one test to the next, to the next, to the next, this, every time you pull the tab off or scratch it or whatever, you should get the same smell within that test. So the results that are standardized and validated probably should be okay, even though people's ability, to name something may decrease depending on whatever product that they use. It's very interesting to see how different smells are manufactured. You think that all of the smells we have are natural products. But one of the things I was going to mention that's not in the written part of this is I saw an article just the other day. Someone, excuse me, was proposing that menthol, smelling menthol, actually had a healing effect for certain kinds of brain diseases, including certain types of dementia. I'll have to see more on that before I believe it, but menthol it can be extracted from several forms of peppermint that is a naturally growing substance. But a guy back in early 1900s won, to early 2000s, won a Nobel Prize for a totally artificial chemical synthesis of menthol. And it's used in many things, from Vicks Vapor Rub to menthol cigarettes. It's a popular smell, and it's it may turn out to actually have some value to it. So it's interesting.
Here, just pause. And we want to have time for questions from 20 meters. This is Whiskey Bravo 5 Delta, the Medical Amateur Radio Council, Graham Brown to the Internet. We've had N5 RTF. We've the majority of the discussion. N3PQ with input, and N4JL. This is AA4FL operating out of Hawthorne, Florida. And interesting enough, Chip, N5RTFI recently stopped using nasal sprays before CPAP, worrying about using those particular sprays every night because they're not really intended for that purpose. So what did I do? I took a little Vicks vapor rub, and I wanted to make sure menthol wasn't going to harm me. So I think you just validated that for me, that certainly perhaps won't harm me, although I don't use it every night. I'd like a chance to, a friend 5RTF, to field some questions, or if you have late check-ins on 20 meters, make your call to Whiskey Bravo 5 Delta and we'll make a list. Okay, I don't know if this is a very quiet 20 meters today. We're in the middle of a coronal mass ejection. Today we discovered something new. Us that are in healthcare consider CME to be continuing medical education. And we just found that if you're going to sync that with a coronal mass ejection CME, you must use Zoom. So I appreciate those of us that are allowing the Zoom simulcast today. I'm going to turn the microphone back over to Chip. And Chip, if you'd like to ask for further questions here on the Zoom simulcast, you go ahead and do so.
Yeah, this is N5RTF. Just a couple more things about doing the tests. You don't want, if you're going to give a smell test to somebody, ask them not to eat or drink for about 15 minutes before a test. And also, if you're giving multiple stimuli, if you're giving multiple smells, allow about 30 seconds between the scents for the nose to return to baseline, for the old smell to wash away. You want to turn off all fans, air conditioning, heaters, close the doors and windows, not have the air blowing through the room. I've got a ceiling fan on in here. You don't want that. You want a smooth laminar airflow, and you want to slowly bring it up from arm's length up toward their nose so that you can detect, you want them to report when they first detect the smell. And you can try one nostril or the other, but again, there's no lateralization. Everything goes to the same place. So it doesn't really make a whole lot of difference. Unless one side of the nose has, some problem, polyps or blockage, or So again, if you get abnormalities on the screening test, then take the next step and use one of the other tests that are available, and you'll be able. The more tests that you have that agree with each other, the more valid your diagnosis is going to be. So this, again, an N5RTF. Are there questions?
I have a question for you, Chip.
Please.
I was just curious about acquiring these tests. I just did a quick internet search, and I came across a company that sells their one-time use kit. It says it's UPenn testing. It was $29.50, and they sell them in groups of 7. So I think the minimum purchase from this particular company, Sensonics, I believe. I took a screenshot on my phone just for so I'd remember. But so it's an investment of like $200 and some odd for one-time use tests times 7. Does that sound about right, Chip?
I think you can do better on Amazon. I think you can get individual tests on Amazon. The last time I looked, I would shop around before I did anything. If you're working at a hospital, a medical center, or whatever, you can check with your procurement people, and you can make it just with approval by the pharmacy board. You can get it you can get it as incorporated as just a standard test, and let them bear the cost and the reimbursement for the testing. I know that our clinic, even though psychiatry doesn't do a lot of testing, our psychologist would pay. They would have to purchase the pencil and paper tests, every single one of them that they did. That was not public domain. They had to buy these things in bulk and keep them in stock, and they couldn't just put it on the copier and run one off and do a test. Somebody had to be paid every time an MMPI was run. So you could do the same thing with this if you're part of a group or a hospital or some other practice. So that's a possibility. Talking about the nerves going through the cribriform plate and things that people spray up their noses. I don't think the general public is aware of just how delicate that area of your body is, that it's literally millimeters from your brain. And we had a child that got amoebic meningitis and died in the nearby parish from a slip and slide, running and slipping on a slide, and they had amoebas in the water supply. And he got them shoved up his nose and died from it. Neti pods, you've seen that as a popular thing that's advertised. It's a contraption of glass vials full of water that shoves water under pressure up your nose to clean out your sinuses. That could very, very easily put bacteria or viruses up through the cribriform plate into your brain, and very dangerous thing to do. People just don't understand how fragile that area of your body is. You pay a price for your sense of smell in fragility and extra risk of infection. There was the two places that do the most in smell research is Pennsylvania, University of Pennsylvania, and University of Florida. The people at the University of Florida, they seem to be in competition with each other. People in 2013, the researchers at the University of Florida reported that a smell test using peanut butter showed normal function in the right nostril and decreased sense of smell on the left side of persons with cognitive impairment. They thought this was an actual test for Alzheimer's. Penn University of Pennsylvania repeated the study the next year and failed to replicate the results. That would make sense because, as I said before, the nerves from both olfactory bulbs cross over and they go to both sides of the brain. So there really is no lateralization. And covering up one nostril and smelling something as opposed to the other one really says more about the anatomy of your nose than anything else. It really shouldn't tell you anything at all about brain function. So the peanut butter test at this point in time is not recommended. Sorry, Jay.
That's okay. Just because I'm faculty at the University of Florida, I'm over in the College of Dentistry, so but yeah, I included some information here for links. If you're going on to the YouTube video that's recorded later, you'll be able to access this information. So if you go to healthcarehams.org right now, the slides with the active links are published. Just look for the post section. So even though you're here on 20 meters having a net, and you're participating in a net, and you're hearing all these ham radio call signs for identification, now you can go to our website, and in this particular case in real time, look at the actual slides that we're using to prompt the discussion today. In addition, we are recording this for a YouTube video. And on the YouTube video, the general public who has questions about this subject matter will then not only be able to find out about our perceptions of the issue, but they'll also be able to find out about amateur radio, what an amateur radio net is all about. So I don't know if we're being stealthy and trying to recruit more amateur radio operators, but hopefully individuals will find it fascinating and see the value of being an amateur radio operator. So I did include those links, and you can get those from the healthcarehems.org. There's 2 links. Was actually one YouTube video from the University of Florida that explains their process and their interpretation of the peanut butter test. And then there's another YouTube video that's more generic from another organization, but there's also a link to the research article by Doty that talked about this particular test and that they couldn't replicate it. So, and he mentions in the study, the scientific study, that there's a clear demonstration of the lack of asymmetry in olfaction with AD. This is what Chip's been talking about here, that we don't have the symmetry. It doesn't matter which side. But in doing the study, the benefit was he replicated or reaffirmed that there's an early smell loss in dementia. So that was a positive outcome, even though their University of Pennsylvania might have found a different outcome in terms of the peanut butter lateralization. There were different reaffirmation of the general principle. So the research often brings up questions. Those questions then bring up other questions, and then Socratic learning here. When we observe or listen or participate on our net, and this is often true in the Medical Amateur Radio Council, one good discussion leads to another discussion. So this is Whiskey Bravo 5 Delta, Medical Amateur Radio Council for ID. We're here, coming at the top of the hour. We're going to have a little bit more discussion today before we close the net and return the airwaves to the general public. We know some of you are going to be listening on YouTube, and you're going to find this very, very helpful information that you're going to ask your health provider about to get medical interpretation, because this is not medical advice. This is just a live discussion amongst amateur radio operators who have a passion for amateur radio and healthcare. But that study, the lateralization smell test, again, is available by link. Go to our slides, you'll find that link, or just Google the lateralized smell test for detecting Alzheimer's disease. Failure to replicate it. The 2014 article in the Journal of Neurological Science, and it's available online in its full PDF form. You don't have to worry about the access to it. It's public at this point. So, Chip, if you have a little more discussion, please go ahead on 5RTF at this time. I'd like to hear momentarily from Mike and for JL from Florida State, our other university up the street here in Tallahassee, and we only have a rivalry in sports, so it's only one day a year. It's a problem for us, Mike. We don't have to worry about peanut butter and smell tests. But let me have my Chip finish up here before we turn over and get a compare and contrast what Mike found with AI and tell how it's used at FSU in medical education. N5RTF, go ahead, take the mic.
Well, thank you. This is our N5RTF. That was the end of my prepared information. By the way, the condition that I was trying to recall a while ago was the normal pressure hydrocephalus, which I've only seen 2 or 3 cases, but it's worth checking for, because it's in some cases it's completely reversible if you get it early. So it's one of those nice dementias that can go away. At one time, they thought that delirium was reversible and dementia was permanent. Turns out that some dementias are curable, but every delirium puts you one step closer to the grave. So of the 2 of them, neither is good. But delirium doesn't need to be under evaluated, and dementia, you need to keep your eyes and mind open for the possibility that say just a B12 shot might might completely reverse it. So those are important things too. So I'll turn it over for questions, comments. Anybody else that wants to add anything? I feel like this topic was cursed because I gave it before. We had 6 wonderful people checked in, but we didn't have a Zoom recording, and I couldn't get my own voice on the SDR network. It was propagation was so poor that day, so we didn't have any recording at all. We have a recording now of this both on Zoom, and we also will have an audio recording. So I've got that set up, and I'll load it this morning when we're through. So it's we've got a couple of dozen people checked in, and just very, very glad that I think it's a worthwhile topic, and I'm glad that everybody checked in. And so any additional questions, comments?
And none heard. Thank you, Chip, for excellent discussion and putting this forward in Manir N3PQ in addition to N5RTF. It's nice to have not only the psychiatrist here for the overall discussion, but also hearing it from a neurological point of view from N3PQ. And for those that have also offered another way, which we're about to transition here over to Mike. So N4JL, I've got a couple of questions for you as you start this discussion about the AI research you did, and as you might compare and contrast what you found to what you just heard from health professionals, but also in the legal field. I mean, how much are students relying on AI these days? I mean, are they taking to heart what they find in terms of their different internet research, whether it be AI generated or self-selected? And I mean, how much are they counting on it? Are we using it as a tool, or we're using it as a solution? And in the law profession, the same thing. I mean, are attorneys preparing briefs? I mean, are they getting embarrassed in front of judges when they come in with AI generated briefs? So maybe a little bit just overall discussion from you on what your findings are and what your feelings are about AI generated research. Michael, thank you for preparing it here today. Go ahead. Unmute if you would, Mike. Unmute.
Can you hear me?
Yeah.
Okay. In the legal field, just like other fields, we are dipping our toes in the water, some with more enthusiasm than others. AI hallucinations are appearing in legal memoranda and briefs filed in courts. It's surprising to me it's still happening. It's been well known for at least over a year. Never trust anything that was generated by AI, but sometimes it's useful in doing research. It's also being used in cleaning up memoranda. For instance, I took one of my old briefs that I had filed many years ago in the Florida Supreme Court and asked, I think it was Chat GPT 4.0 to clean it up, make it sound a little bit better. And I would have accepted 2 of the suggestions that Chat GPT made and incorporated in my writing. The other suggestions were pretty sorry, and so I ignored them, would have ignored them. But hey, 2 suggestions out of a whole brief isn't too bad. And so it is being used somewhat. It's causing embarrassment when hallucinations are used. People should know better. It's now close to malpractice to have that happen. And courts are imposing very heavy fines on attorneys who do use AI generated material and have false statements in it. I was curious, I was remembering the University of Florida peanut butter sniff test. And so I thought, what would AI look like in response to asking about olfactory impairment as a way to diagnose dementia? And so I tried several of the AI chatbots that I have access to. And Claude And Gemini responded with some very good information, which I thought was useful. I apologize if it's posted. The Perplexity link is dead. And Copilot came up with a very recent study that has the link, and I think is sort of what's the current state of the art in studying this. So in some, I thought AI was useful, but of course must always be used with caution.
Any questions for Mike and for JEL? On
Yeah, I have a question, if you
you
please.
have Munir N3PQ. Go ahead.
Yeah, hi, this is Munir. I'm 3PQ. Hey, Mike, here's my question. I sometimes use Perplexity AI. It seems to be straightforward. And then whenever they answer a question, they give references. So I always, if I'm suspicious, I go to the reference, to the source. Where did they get the information? Sometimes the references are very legitimate references, like an IH publication. Sometimes it's somebody trying to sell something, or somebody who has an axe to grind, or somebody who is not reliable. So I think it's important, if AI gives a response, to see where did they get the response from. After all, what they are presenting is nothing original. They're just doing like a super search on the internet and presenting us the evidence. But I think it varies based on the sources they use, how much we can rely on their data.
Well, it certainly does. Perplexity is a little bit more inclined to give you results that kind of look like a Google search. And as you all have noticed now, your Google searches are starting to look a little bit more like an AI chatbot response, which is kind of interesting as the two modalities overlap. But yeah, I always check the references, and occasionally I get the same response that you do. Perplexity just picked up a bit of trash.
Thank you, Mike. Does anybody else have questions on 20 meters here? Do we have any questions for N4JEL? Go ahead and make your call to WB5D. Do we have any late check-ins? So we hope that other amateurs are monitoring on 20 meters directly here, even though we know today's got a solar storm. But any other questions? WB5D or any late check-in? Okay, we do have a station, but unfortunately, propagation's not in our favor here today. Go ahead again.
Charlie 3, Victor Golf.
So Zulu Victor Golf Kilo Charlie 3. I'll go ahead and relay if we need to. But what are your comments or questions? Go ahead. Okay, thank you for forwarding or trying to forward a question. Of QSB fading. For those of you not amateur radio operators, they were having very bad solar conditions. When you're an amateur radio operator, we have it's not one hobby; it's a collection of sub hobbies. On shortwave aspects, we have certain conditions of the atmosphere that affect our ability to communicate between points of the Earth. It's a very vibrant hobby. So some of us use equipment on the International Space Station. Some of us use satellites orbiting in space. Some of us are interested in emergency responses locally. So, check out ARRL.E. Mike, do you have any further comments before we call the net to a close? N4JE, I'll go ahead.
The only thing to mention is the medical school will introduce artificial intelligence formally in their curriculum this coming fall. So the students will have an introduction to it. I have no idea what the scope of the how much emphasis will be placed on it, how much time in the already incredibly crammed instruction for the students, but this is a formal recognition of it. And for JEL.
N4JL, AA4FL, Mike for WB5D. I concur. At the University of Florida, they're also AI very heavily invested. And we had a large donation from the co-founder of NVIDIA, and AI in the medical school is actually, I think they have an area within that brand new building, even outside of the hospital section, big research. So across campus, we're really, they are really emphasizing it. In dentistry, of course, we see it too, because in dentistry, we have a lot of CAD/CAM manufacturing, computer assisted design and manufacturing. And then if you couple a scan of an image of something that's present in the mouth, then you can also have AI interpret it and offer solutions. And that hasn't happened yet, but as I explained to my students, I anticipate that's going to happen in the future. There's one clinical situation where they're making removable prosthesis for patients to wear partial dentures, and they physically put this on a little table and tilt a model to find the best vector solutions for the design of the partial. There's millions of possibilities. How can anybody do that with their brain? I explained them, and maybe not in my lifetime, but in their professional careers, the computer will analyze it, and the AI will give them the potential solutions and modifications, much to the benefit. As Mike was saying, these are tools. These are tools that it's our brain power. We have to use these appropriately and know when they're relevant and when they're not. At the end of the day, we're responsible for our legal careers. We're responsible for our medical careers. They're just tools. They're not a panacea. Any follow-up to that comment, Mike, and for JU?
No, but thank you very much. I've enjoyed working with the students so much, and we'll continue to follow them as they integrate AI into their profession.
Yeah, Mike and I, we're the generation where that's their future, not our future. We're I wouldn't necessarily say we're the past. We're the wisdom. Yes, but they're the actionable individuals now that are doing the work. So thank you for everything you do for the students. And for JL and everybody else that participated today. Do we have any follow-up comments before we bring the net to a close here on Zoom? Go ahead and make a call to WB5D.
Just a quick comment.
Okay, WB1FFI from Syracuse, New York. Go ahead, Barry.
Yeah, this is Barry, WB1FFI. I want to thank everybody. I thought it was an excellent presentation today on both by Chip and Mike's follow-up on AI. Just to follow up, Chip, I tried to go on to Amazon. They do have smell tests, but not specifically the UPenn test. So I may have, because I'm on my phone, it's not as good as using my laptop or a desktop. So if you can find a link to that, that would be great. Just because I think it's a relatively low cost thing that would be interesting to experiment with. I just don't know if I want to make an investment in 7 tests at $210 right away. But that was the official test that I came across, this company called Sensonics. So that's the only comment I wanted to make about that. But I found the topic fascinating, as I'm sure we all did. And thank you again very much. Back to you, Jay.
Yeah, I thought I'd seen it one time. Maybe that was just in a Google search and it was for sale somewhere. If anybody really wants to do it, I would check with the University of Pennsylvania and find out if they are actually selling the kits. That might be the best place to get them, because they would give you some hand holding service as well as just selling a product. You could ask some questions if you needed to. So sorry I had to leave. Are we recording, Jay?
We're still on Zoom here, and I appreciate the input. By the way, I would assume they're probably selling to health providers. So it wouldn't be difficult to find 7 individuals like to share it with you, Barry. We're going to be on airplane going to Europe, 5 couples. Wouldn't it be wonderful if we smell tested ourselves? I guess you can't because you can't shut off the air conditioning or control the smells. Oh, it sounded wise, but it was foolish because Chip told us all the things we can't do in life. But I will make one more comment about buying things on Amazon, Barry. If you're going to be buying smell tests on Amazon, make sure they don't stink. You gotta get some quality there. Any other further comments? This is AA4 FL at the mic. Make your call to WB5D. Any comments on 20 meters or questions? Go ahead and make your call. Well, thank you for everybody that participated today. I'm not sure what we're going to talk about next week, but we've got a week to discover it, and we'll announce it here. So if you're not a healthcare HAMS member, a Medical Amateur Radio Council member, of course, we're open to all amateurs. Go to the healthcarehams.org and website and see all about us. If you do become a member, then you'd be getting access to the notices about the YouTube videos, the Zoom links, et cetera, et cetera. It's not required to be in the healthcare fields to be a member. We encourage everyone to participate, but we're certainly there for the general public, for the general amateur community. And thank you for allowing us the use of the frequency of those hands here in 20 meters a day. That being said, we're going to bring the net to a close, return the frequency to general amateur use. Look for marcoaudio.net for the audio feed later. We're going to be closing that recording now, and look for the YouTube video as well on our YouTube channel, which is Healthcare Hams YouTube channel. It's 7-3, everybody, bringing the net to a close.